Okay. Yes.
Okay, we're gonna do a quick panel. Please, questions?
Yes. Hi, for Jillian. You showed really cool data about a potential EEG biomarker, which is very exciting. But you also mentioned you want to look at CSF protein biomarkers. I'm working with other communities. We're looking at that. And we're finding that getting through IRB to collect CSF for this type of study is really, really difficult. So diseases that already have trials with ASOs, they're sampling some CSF from that. But if you don't, it's like super difficult. How are you planning to do that? Because I want to learn.
So we're still very early stages right now. So the first step is we just want to actually, we have a biobank of like healthy children's CSF, and we just want to see first if we can quantify Syngap in the CSF. So we're not there yet, but maybe we'll learn from you.
So heads up, ethics is yeah.
A great session, everybody. Thank you. This question is for Dr. SmithHicks. I always worry about sleep hygiene when it comes to measures and parameters of sleep in our kids. Are there certain measures, parameters of sleep that are less susceptible to sleep hygiene, such as the sleep disordered breathing?
Yeah, that's a great point. Sleep hygiene is certainly a challenge in this population. So certainly sleep disordered breathing is less, does not capture sleep hygiene. But I think one of the things that perhaps will allow us to separate sleep hygiene from other sleep challenges would be actigraphy, right? So sleep hygiene certainly captures, the setting of the room and the environment that facilitates sleep. And that sort of data we get from questionnaire-based, just clinical questionnaire-based, but I'm not aware of any validated measures that sort of get at that question.
I have a question for Jillian. Based on the preliminary results of END, what do you anticipate will be the primary endpoint for future clinical trials?
The $1 million question. So seizures are obviously what most people reach for first, but as Megan outlined nicely, there are some problems with the countability of seizures in Syngap, and not everyone has seizures. So I think seizures are potential, but then some of the motor scales actually are looking really promising as well. Now we're seeing like a good developmental trajectory that we could potentially see a response to therapy for those. And then potentially like a QEEG biomarker, I think are the most promising right now.
Thank you.
Thank you for those great talks. I have another question for Jillian. You mentioned alpha-occipital ratio differences, and I'm wondering if those persist to later stages when the patients are seizure-free, and if they have correlation with eyelid myoclonia, which has also been reported with these children.
Yeah, so you mean specifically like the QEEG biomarker I showed, that occipital alpha theta?
Yes.
Yeah. So we're doing this on all individuals, whether they have seizures or not. We haven't looked separately, which would be a good analysis to do. And we haven't looked whether they correlate yet specifically with certain seizure types. We've just looked across the whole population, but those would be good things to look into.
Thank you.
So I have another question for Jillian. It's a simple one, hopeful, also worth $1 million for you. So you have all the genotyping information of your patients. So do you see any, did you do any genotyping, phenotyping correlation? I'm especially interested in those missenses.
Yeah, that's a great question. So we have looked and haven't seen anything that stands out very strongly. The presumed mechanism of disease is haploinsufficiency, and most of our variants are protein truncating variants. The one exception to that is variants in the first 4 exons, because there's an isoform of Syngap that starts at exon 5. There's been some like lore that they're milder. And And very preliminarily, you see some differences on some of the developmental scales, like the classification scales, specifically with like communication. But it's a little too early to tell because we don't have that many individuals with variants in the first 4 exons yet. But that's something we're looking into.
Another one for you, Jillian. Sorry. Not $1 million question, more of a data and logistics question. One of the things that I know that End is asking of our organization is that we try and get patients to y'all every 6 months. And as one of the people working and pushing people to get there, I know it's difficult for families. And so I wanted to see if you could speak at all to sort of the data issues you might have if we are struggling to get people there and because I'm trying to encourage a lot of these families here. We've got 70 families here that we want to come to one of y'all's clinics. Can you speak to like the importance of every 6 months, the data issues you're going to run into if we can't keep trying to regenerate people getting there every 6 months, et cetera, trying to drum up support?
Yeah. So we would love ideally for everyone to come every 6 months, just so you have like a standard interval between assessments. It's more important, honestly, for younger individuals because development can change a lot when you're like 2. Whereas if we have some adults and when you're 30, we're not necessarily going to see huge changes over 6 months. But we don't want to discourage people from participating if every 6 month is a barrier. We still would love you to come. And then we're hoping that by having more sites across the country, it will help alleviate some of those barriers as well. We're going to share our data between sites. Like you can come to CHOP for your first visit. And then if you live in Colorado, go see Megan for your second visit. Like that's totally fine. It's so tricky. I think under like 5 for sure, even under 10 would be great. But,
Heather, we just had a chance to come see you last month, so it's nice to see you again here. More of a minor point, I guess, and it could be addressed by any of you guys, but there's inherent difficulties in data collection as it is. One of the things that's coming to mind is that, say, for example, an example might be a better way to phrase it. If you're asking parents, do you have sleep difficulties? Well, is that considering the medication factoring into it? So we could answer no because he is artificially induced into a sleep state because of his medication. So does that, when you are asking the questions, does the medications they're on influence the answers you're getting?
So the medication likely does influence the answer, but the idea is that individuals can be on a lot of different meds that may treat sleep problems, but sleep problems still exist. So it's rare that we get an individual who is on no medicines at all, and so we can know what is the nature of the sleep difficulties as it exists in the natural setting. So knowing if they're still having sleep problems despite being on meds that should treat sleep should give us insights in how well is sleep being managed, and is treatment of sleep still a gap and still a need?
Hello. My question is toward Jillian. Sorry. We recently did a small number of cohort study with Syngap 1 patients, and I have several questions about that. So we felt that in the individual level, a lot of the patients, as they grow older, especially they pass the puberty age, the seizure control gets better. And sometimes they even go seizure-free. I was wondering whether you found similar findings in your cohort studies. Second question is, with your anti-seizure medication response, I noticed the valproate acid and the lamotrigine was a significant one. I was wondering how you analyzed patients who's on polypharmacy, because I know valproate and lamotrigine kind of interact together and they have a synergistic effect. And I was just wondering whether lamotrigine was kind of piggybacking on valproate, possibly. Yeah.
Yeah. Okay. I'll answer that one first, just because it's fresh in my mind right now. For that specific analysis, we didn't factor in polypharmacy. So we just looked at like time periods when they were on that med versus all other time periods. So there could be some interactions captured in the data as well. And then in terms of the seizure history, right now we have a broad sampling of individuals across the age span, but we haven't seen everyone for longitudinally yet. So it's a little hard to say. There definitely are patients who have seizures and then their epilepsy remits as they get older, but I don't think we have enough longitudinal data of over that time course of going through puberty to be able to say like definitively.
Okay, then I just want to say for every parent that is here, most of this data comes out of the parents filling up assessments, and all the clinicians work very hard, but if we don't have parents that are very good about filling these surveys, we are not going to have data. Then please help with that. And one question for Megan that comes out of the mandate or kind of the latest of the FDA to be able to promote the studies is that you have to have family participation basically, and that comes out of the study that put clinicians and parents assessment together. And that's very important for the FDA if you can tell the families how important it is.
Yeah, I think I highlighted in my talk that I think the caregiver perspective is going to be especially important in disease-modifying therapy trials moving forward. You guys are the ones living with your kids at home, and it's going to be especially important that we're measuring meaningful change for you. And so when we're talking about assessments and things that we're doing in the clinic, it's especially important that we're getting caregiver perspective. So those caregiver surveys, I know surveys are very annoying. No one likes their email inbox filled with surveys, but it's going to be really important and crucial moving forward for Syngap 1 clinical trial readiness.
I think we finished the session. Thank you so much.